Welcome, everyone. I am Dr. Chris Araujo Torres, and I head the Medical Affairs team at Nestle Health Science in the US. I will be moderating today's presentation titled Personalized Nutrition Management Across the Continuum of Care in COVID-19. Financial support for this presentation is provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only, and not intended as a substitute for medical advice. So I am very pleased to present today's speaker, Dr. Paul Wischmeyer. Dr. Wischmeyer is a critical care, perioperative, and nutrition support physician who serves as a professor with tenure of anesthesia and surgery at Duke University School of Medicine in Durham, North Carolina. He also serves as Associate Vice Chair for Clinical Research in the Department of Anesthesiology and as Director of the Nutrition Team at Duke Hospital. Dr. Wischmeyer's clinical and research focus is in critical care, nutrition, and perioperative care to help patients prepare and recover from critical illness and surgery. His research interests include ICU and surgical nutrition therapy, perioperative optimization, post-illness lean body mass and functional recovery, and the role of probiotics in the microbiome in illness and cognition. Dr. Wischmeyer has received numerous awards from national and international societies, including the Jeffrey Silverstein Award and Memorial Lecture for Humanism in Medicine from the American Delirium Society, the Honorary Samuel Rowling Lecture from the Royal College of Anesthesiology, the John M. Kinney Award for the most significant contribution to the field of general nutrition, and the Stanley Dudrick Research Scholar Award from the American Society for Parenteral and Enteral Nutrition. He received the George Blackburn Award for Research Mentorship in Nutrition from Aspen in 2020, and also received the Lifetime Achievement Award of the International Parenteral Nutrition Education and Methodology Advancement for significant contributions to the field of nutrition. In anesthesiology, he has been named to the Foundation for Anesthesia Education and Research Academy of Mentors. Dr. Wischmeyer has over 165 publications in nutrition, critical care, and perioperative care. He has been an invited speaker at numerous national and international medical meetings, delivering over 700 invited presentations over his career. He is also passionate about training and preparing new young physicians and scientists for careers in academic medicine, perioperative ICU care, and clinical nutrition. Finally, he is an advocate and lecturer for improving the patient experience and teaching healthcare providers to keep care as the focus of healthcare. Welcome, Dr. Wischmeyer, and thank you so much for joining us. So over to you.
Thank you. It's great to be with everyone today and to have a chance to talk to you about how we can try to optimize and personalize our nutrition management across the entire period of care for our COVID-19 patients. Just briefly, what I will call my alignment of interests, I don't see them as conflicts. I think working with the NIH and other foundations and industry groups to try to improve the nutrition and overall care of our patients is something that all of the groups I work with, I think, and myself are aligned in. So the objectives, again, are to identify the metabolic response to SARS-CoV-2 infection, to discuss results of our new trial of metabolism, the LEAP COVID trial in critically ill COVID-19 patients, and discuss the guidelines and how they may fit into our new data for delivering nutrition in this group. I think further we'll talk about the management of macronutrients and actual little micronutrients across the continuum of care in COVID-19 and talk about some of the things we begin to think about to improve our post-ICU outcomes. So I think the key message that I always try to convey in all these lectures is we must take responsibility not just for the outcomes of our patients in the ICU, whether they have COVID-19 or not, but also what happens to them after the ICU. Because ultimately, our goal is to create survivors of our patients, survivors that go back to a life that is meaningful to them, and not victims of our patients who perhaps leave our ICUs to go to rehab centers or go back to a rehab center they'll never leave and never go back to being able to walk down the street with the people they love, hold the hands of the people they love, or hold the grandchildren that they so long to see again. And so again, this is, I think, our critical goal, and we need to be thinking about how we're going to ensure and optimize the post-ICU recovery of our patient from the day of ICU admission, and we'll talk more about that. But this is a challenging thing in COVID-19. Any of you, and I'm guessing many of you, have had the challenging opportunity to care for these COVID-19 patients in your ICUs around the world. It's challenging. There's many things happening in these patients. These are amongst some of the sickest patients we've seen in many years on a consistent basis. This is ARDS like we used to see when I was a resident and fellow, or in the beginning of my ICU career 15 or years more or long ago. So this is a really challenging patient population. Now, the good news in ICU overall, and I think this is true, I'll show you in COVID-19 as well, is that we are decreasing the in-ICU and in-hospital mortality of our patients, and this has been true for a number of years. We're getting better, obviously, at saving people from the acute injuries that are threatening them, and this is true in COVID-19 mortality as well. In just the last 6-8 months alone, we have reduced the mortality that they saw in Wuhan from a really devastating 60% down to what we're seeing in New York, which is around 24%, and in some of our LEAP COVID data, we're seeing mortalities closer to 20 to 25%, maybe even a little bit lower than that, as we continue to improve care. But the question we have to ask ourselves in critical care, and especially in COVID-19, are we winning some battles, such as getting people through the ARDS phase, but perhaps still losing the war by so depleting our patients that this is perhaps a Pyrrhic victory, where the patients that leave the ICU are so weak and so debilitated that they perhaps don't go back to lives that are meaningful for them. And so I think we need to really think about how we can counter this. Because although sepsis deaths have fallen by half and COVID mortality has fallen by more than half, at the same period of time, at least in sepsis and critical care, we've tripled the number of people not going home, but going to rehabilitation, where we don't know if they ever went home or back to their families or back to a life that was meaningful. And so clearly we're seeing improved hospital survival, but how many even survive a year? And that data actually we have some sense of. We know that almost half of the mortality at a year following ICU discharge happens after they leave us, or sorry, a year following ICU admission. So within a year of a patient's ICU admission, almost half the deaths occur after they leave the ICU. And so we have patients that we're saving, but ultimately they leave the ICU and within a few months perhaps they're passing away in rehab centers or other places and aren't going back to a meaningful quality of life, which is why many of the expert research groups and the large critical care research groups have said that quality of life needs to be the focus of our trials rather than just solely mortality. And that really our goal to create survivors is really the key goal that we need to be facing. And this is a broad and troublesome problem. This is data looking at the ability for patients to return to work in their 40s and 50s who've had ARDS and have been critically ill. 50% of them don't go back to the job they did before in a year, and a third of them will never go back to work because of the physical and cognitive dysfunction and challenges they face following ICU. And we know that COVID is presenting long-standing fatigue and quality of life deficits, even in patients not in the ICU. The long COVID syndrome that's been talked about in JAMA is real and is occurring in many of our patients. And so no one is immune to this, whether you're young, whether you're old. I will show you all of us are vulnerable to this. And this really is, survivorship is what we call this, giving people back their quality of life, is the defining challenge for us. And Jackie Wishanisha has shown us the emerging picture of ICU survivorship is deeply disturbing. You know, in the years following discharge from the ICU, patients are ravaged. They can't walk, they can't think. Their bodies don't do what they did before. And many of us, all of us, have letters from patients who are so grateful they've been saved, but they're desperate for help in getting their lives back. And that's where you, as the caregivers, the dietitians of the world, really can make a difference. I will show you. So 60 to 80% of our patients will be functionally impaired after being on the ventilator for a week to 10 days. So this affects the vast majority of our patients that we're seeing in COVID with our long lengths of ventilation. This is true after major surgery as well. And I fear that COVID-19 is going to give us a whole new large number of ICU survivors that are facing these challenges. Given that the average time on the ventilator in COVID-19, depending on which paper you read, is 8 to 21 days, these are patients who are going to have significant challenges. And given that mobility in these patients is even more challenging because of infectious risk, it's very hard for us to mobilize people on ventilators or do physical therapy for our patients. This is really going to be a challenge. So why are we losing this quality of life war? And I think a big reason is we know that ICU, like COVID patients or major surgery patients, can lose up to 1 kilogram of lean body mass a day. and that this takes a long time to recover. And we fear this is because the hypermetabolism and catabolism of these patients can persist for months or years after they leave the ICU. We know that a burn child will remain hypermetabolic for 2 years after they've left the ICU. We're not evolved necessarily for this. And in COVID-19, I'm going to show you this hypermetabolism may be worse. Because although our patients can be shown to gain weight back at a year, and this is a study from Margaret Herridge, most of this weight is fat mass because the calories we're giving them are not going to generate muscle, but instead are, because of hypermetabolism, hypercatabolism, turning into fat. And that's largely because we're not evolved for this as humans. Our body's metabolic system was not intended to survive COVID-19 illness or trauma or the major things that patients survive in the hospital, but then have to survive in their lives. We as humans are not evolved for this. And so we have to look at how we're going to work with their metabolism and how we're going to improve their ability to function and retain muscle mass as they move along. And this truly is an epidemic for our patients, not just the pandemic, but truly an epidemic in recovery as well. And so we need to do better. And how can we do that? And I think all of us realize this is going to take a combination of targeted, personalized nutrition, nutritionist therapy, rehabilitation in perhaps new and unique ways, and then perhaps some learnings from athletes who are better at gaining and regaining muscle mass and maintaining it than anyone out there. And their science is always far ahead of ours in the clinical world. So how do we take care of patients like this and give the best nutrition? Well, I think the first concept is one size does not fit all. We can't feed the patients the same thing every day and think that's going to give them the best outcomes. So we need to personalize our feeding and give the right dose of nutrition in the right patient at the right time. And how are we going to measure that? So how are we going to put this into practice? How can we personalize our nutrition across this continuum? And what are our guidelines saying? What can we learn from worldwide experience? I think one of the best ways to go over this is to talk about a patient. And this patient's actually an amalgam of a number of patients that I've cared for in my last months in critical care with COVID-19. We've had many, as I'm sure you have as well. And so he's the amalgam I'm going to use as the case study because we had a few patients show some very characteristic things. So his name's Elijah. He's a 49-year-old African-American male with a cough and fever for 7 days. He has multiple family members who have this as well. He's admitted to the hospital with 3 liters of nasal cannula oxygen, and he's had a recent surgery for diverticulitis and has had some weight loss around that. Unfortunately, within a few hours of admission, his respiratory rate becomes quite rapid. He has respiratory decompensation, hypoxia sets in, and he's rapidly transferred to the ICU where he's intubated. His first blood gases are tragic. His PO2 is 52 and his FiO2 is 100%. He's paralyzed. He's desynchronous from the ventilator, leading to that paralysis need, and then he's ultimately prone, as I'm sure so many of you are doing. So first, how can we best assess his nutrition state? Now we know his weight loss puts him at high nutrition risk, but are there new tools that we have that we're using in our LEAP COVID study, and we hope to start using clinically very soon, that help us assess his risks as well? And I think muscle mass is one of the key features all of us need to learn, both as dietitians and physicians and ICU caregivers, to be assessing. You can see that the muscle mass you enter the ICU with has a significant predictive effect on your survival. You can see there in green, patients with low muscle mass at ICU admission have significantly greater mortality than those that come in with better metabolic reserve. We think of the muscle mass as your metabolic reserve. We can use the ultrasound to do this as well. That last data was CT scan data, but we are using ultrasound now that anyone can learn to do. We've taught dietitians, we've taught nurses, we've taught radiology techs, obviously, to do this. And this can be done looking at the leg muscle routinely. There's actually a muscle-specific ultrasound we're using at Duke where we can take what looks like an ultrasound biopsy of the muscle, and we get pictures like this that represent muscle glycogen, muscle quality, and muscle mass. And it's a probe that's about this big. It plugs into your iPhone or iPad. You can carry it around. It gives you images like this that measure muscle mass, muscle quality, and muscle energy state, which actually reflects feeding. And this kind of data, I hope, is the future. I hope it will be to the dietitian what the blood pressure cuff and the stethoscope is to the nurse and perhaps the physician. I think this is our objective future. But let's back to our patient. Paralyzed and prone now, day 1. He's on some Levophed now because inevitably when they go on propofol and all the other sedation drugs and their inflammatory state is so high, they need pressors. He's on the vent with reasonably stable settings, and he's well resuscitated with a good mixed venous and a low lactate. So should this patient be fed? So our recommendations from SCCM are they should be fed. They should get early enteral nutrition within 24 hours of admission, within 12 hours of intubation. We're advocating to use the stomach and avoid post-pyloric feeding, which is a little bit of a change from what we often hear. But the COVID, as we'll talk about, has a lot of GI dysfunction involved with it. And There's risks to placing postpyloric tubes. If you have an RD team like we do at Duke, we have a phenomenal set of dietitians who place tubes postpylorically with a device. And there's risk in that getting into the airway. And so we're recommending and suggesting NG tube stomach feeding. But what about feeding this patient on pressors? And this is a timely opportunity. I had to write a review that I was invited to write for Critical Care Medicine, reviewing the data about the safety of this right before COVID hit. And so this was timely given how many patients now we're facing this in. And I want to advocate to you that feeding on vasopressors might not only be safe, but it appears to save lives, and it's something we should definitely be doing when patients are resuscitated. There's a large study you should all be aware of that studied 52,000 patients in Japan, and they looked at patients who were fed enteral nutrition within 2 days in the early group or after 2 days in the late group. And they looked at survival outcomes in patients on pressors. And what they found was that 28-day mortality was significantly lower in the low dose norepinephrine group, less than 0.1 mics per kilo per minute. In the medium dose group as well, which you're starting to get into ranges I probably wouldn't be comfortable feeding on. And even in the high dose group, there wasn't a difference in mortality when early enteral nutrition was used, but in most of the doses we typically treat with, there was clearly a mortality benefit, and that is likely due to the non-nutritional benefits of nutrition. This is likely to be due, other studies have shown us, to enteral nutrition, and it's trophic enteral nutrition. And so again, we're seeing the early enteral nutrition associated reductions in mortality in ventilated patients on these doses of Levophed. And so I think there's a safe way to do this, and I want to emphasize that this is likely due to the effects of enteral nutrition on the microbiome, on the gut barrier function, on signaling to the vagus nerve. Protein and fat in the stomach and then the gut signals the vagus nerve to reduce systemic inflammation, and then preventing translocation of toxic mediators into the lymph, which into the lung. So there's 4 potential benefits that seem to be the non-nutritional benefits of giving nutrition to patients on vasopressors. And I think that is a key thing to take away from this, that a lot of studies are showing trophic feeding may be better than full feeding on vasopressors, and that's where I would probably start. And so to do this the most safely, you have to make sure your patients are resuscitated before you feed on vasopressors. And I think looking at mixed venous, looking at lactates, pressor doses are falling, the resuscitation is successful, and clearly keeping the doses reasonably low, probably less than 0.2. And then clearly there are certain drugs that have higher risk to the gut than others. Norepinephrine appears to be the safest, followed by things like epinephrine, and then vasopressin and dopamine seem to have the most devastating effect potentially in gut perfusion, and so they have the highest risk. Start slowly, advance slowly, definitely feed the gut and watch for signs of intolerance. You want to monitor gastric residual volumes on patients on pressors. You have to know what's happening in the gut, and that's one of your monitors. So again, I can't emphasize enough, in patients on pressors, feed the stomach, not the small bowel, watch for residuals and other intolerance signs. It's the best monitor you have. So moving forward, same patient now. How much should we feed? And should we feed in the prone position? And so I think this question comes up a lot. I won't spend too much time, but we have trials now showing that it's safe, and we've been doing it at Duke, that you can definitely feed in the prone position. Perhaps elevating the head of the bed a little bit is going to help, but again, this appears to be safe, and I would definitely be trying to do this for your patients, so you'll have long periods of time where they're not being fed. And this is a safe thing to do, it appears from the research that exists. So how much to feed in this early phase of critical illness? What do our guidelines say? So again, we need to be thinking about starting with a hypercaloric or low dose feeding, trying to achieve a goal of perhaps 15 to 20 kcals per kilo is what our recommendation has been, and then reaching protein goals in a few days. And this is because, again, we don't need to give full feeding in this period, because in well-nourished patients, as the body breaks down muscle to generate amino acids and energy and glucose, the body can make 50 to 75% of its own non-protein calorie needs for the first few days. So we don't need a lot of non-protein calories, or we will be overfeeding. And that's backed up by studies like this, that in 1,000 patients, the lowest mortality early in critical illness was derived at 70% of measured resting energy expenditure. And so again, this is because the body's likely making its own calories in well-nourished patients. And so it's good probably to start your feeding slower and keep your calories low. But this is a new disease. COVID-19 is a new pandemic disease, and we need data that is measured to really know what's best. And so again, indirect calorimetry, I think, should become much more common. We have a new device out there that all of you may have heard about, and our guidelines recommend it. The ESPEN guidelines recommend measuring with indirect calorimetry. The ASPEN guidelines recommend it as well. Clearly, we know that our equations are highly inaccurate in relation to the reality of obesity and the common severe critical illnesses that we see. And there's a tendency for indirect calorimetry to even reduce mortality. There's a meta-analysis of studies that looked at using indirect calorimetry to guide calories. And those studies that used it tended to show nutrition gave better outcomes and perhaps even reduced mortality with a relatively strong signal, just about significant for statistical significance. And this is a new calorimeter, indirect calorimeter, and we won't talk about the product or the name of it, but you just know there's a new one out there that you should explore that is rapidly usable. It's small, it rolls around in a cart, and it gives you rapid measurements in 10 or 15 minutes, and it calibrates itself. So you don't need all the hours and time and expertise for those old devices that were so hard to use. This is a whole new generation of calorimeter that we're using. In our study of COVID patients, the LEAP COVID study, this is Jeroen Mullinger, who at Duke has really been a hero in going into and spending 10 or 12 hours a day in COVID patients, very sick COVID patients' rooms, measuring muscle mass, measuring indirect calorimetry, measuring body composition. You can see some of the devices that we're using, and that's the actual size of the indirect calorimeter there he's got on the right side. So this is a study that we wanted to see what is happening in the acute phase to these patients, and our COVID-19 patients hypermetabolic in the acute phase. Well, even our TV doctors know that in general ICU patients are not hypermetabolic in the acute phase. And so we wanted to see, is this true in COVID patients as well, because that data doesn't exist yet. So again, in this study, every 3 days from ICU admission to hospital discharge, we're measuring metabolic cart, muscle ultrasound, body composition, and echocardiography. And these are the results we're starting to get. So this is data from the first few days of COVID critical, and this is a critical care patient with COVID-19. It's a mid-50s patient, an LTAC patient, early in care, day 2, spontaneously breathing on the vent, not paralyzed. 15 kcals per kilo was actually the resting energy predicted by the Harris-Benedict, and we measured about 70% of that predicted. So again, the 15 kcals per kilo, I'm sorry, is what the indirect calorimetry predicted. So about 70% of what Harris-Benedict would have predicted. So again, lower hypometabolic appearing. This is another patient. This is the patient I'm describing to you actually. This is a patient that's on day 4, and you can see our outstanding ICU dietitian, Leslie Murray, was right on the nose. She was feeding 1440, and this patient was predicted at 1478. So, and again, this was actually a prone to paralyzed patient. This test was done on a PEEP of 12. The new calorimeters measure a much broader range of patients than the old calorimeters used to. So what about as patients move into the chronic phase and perhaps the recovery phase? What happens over time? Well, we hypothesized they'd become more hypermetabolic, and they did after the first week. This is that same patient on day 12 who's being fed 1440. Now they're 2436, 35 kcals per kilo per day, predicted by indirect calorimetry. And so we needed to turn the calories up in this patient. As you can see over the next few days, this continued to change. This patient became more hypermetabolic, now at 45 kcals per kilo. Again, we didn't adjust it because this patient had been febrile. We wanted to see how this would run, but you can see the variability from day to day in these patients over time. And then they dropped a few days later, day 18, patient was improving some, and they dropped 1879. And so we kept the feeding at about 2100. And so again, the challenge was this patient got sicker again on day 23 and jumped back up. And so again, there's a lot of variability, and this patient became very challenging to feed, and we'll talk more about that later, but you can see the variability that's occurring as the patient's clinical status changes. So we've summarized a number of these patients now. This is 22 patients that have had COVID that we've got complete data on now. You can see the people we studied are about 58 years old. Their range of age was 31 to 88. They were largely African-American males, about half and half males and females. They were on average obese. That seems to be true in the ICU COVID patient. Obesity is very common. 12 of the patients had a BMI over 30. So again, their average time in the ventilator just within the 21 days I'm reporting data for was 14 days. So they were pretty sick. Their mortality was about 14% in the 21 days and 22% over the whole hospital stay. So about what we were reporting on average. So you can see what our calorie measurements on average were. These are actual body weight measurements. They start at 1500 the first week, go to 1800, and then to 2700, almost 2800 in the third week. So there's this progressive hypermetabolism that you can see. I've got data as weights based as well. This is based on the non-obese patients on actual weight, about 29 kcals per kilo. And then again, and that's resting energy expenditure, doesn't account for activity. And then you can see in the obese patient, it's slightly higher at 32.5. And that's on adjusted body weight, which is what the ESPN guidelines recommend. You can see these are challenging patients to feed. We fed about 10% of needs, or 9 calories per kilo, sorry, not 10% of needs, but 9 calories per kilo, about 40% of needs. And so these are very challenging patients to feed. This is what the VO2 and VCO2 data showed. I wouldn't have a lot of time to go over this. The RQ is that top line. The RQ is quite variable. We use it to help us look at over and under feeding. We can also look at substrate utilization. John Whittle, who's one of our ICU physicians, analyzed all this data. Thank you to him. And so this is the respiratory exchange rate there, the VO2 there, and the VCO2 there. This is the average kcal resting energy expenditure, the raw data for all the patients. You can see the extreme variability across all the time points. This is why measuring is so important. This is actually on actual body weight, not ideal body weight, forgive that. These are the non-obese patients now on actual body weight. You can see they trend up and peak at about day 17. There's some slight downtrend with a lot of variability between day 15 and 20. So you have people that are as much as 2 times predicted in that period of time. And so this is the non-obese patients. And then this, there's the line of the Harris-Benedict predicted. So you can see they're way above predicted hypermetabolic, about 150% on average. These are the obese patients. There's the Aspen 11 to 14 kcals on actual lines. There's the actual measured, both on actual and adjusted body weight. Adjusted body weight's in purple. Actual body weight is in blue. These weren't statistically different. So I think this is about where the obese patients, you can see they remained hypermetabolic and exceedingly variable late in their care. We have data that was beyond day 21, we'll report to you soon. This is putting all the data together. There weren't differences between the obese and non-obese, although there were trends to differences. You can see how they trend differently. This is the variability, thanks to Krista Haynes, who's one of our trauma surgeons and ICU docs, who looked at the variability from day to day in this group, and you can see the extreme variability and why measuring is so important. These are all the patients together. The green line there represents the fed calories that we have collected so far. You can see it was tough to feed these patients. You can see about 12% of these patients were prone at any given time, and that extended out to day 21. About 10 to 15% were paralyzed, and their SOFA scores didn't change very much. So these hypermetabolic events don't appear to be related to their acuity of illness or the use of paralysis that we can see. This is a trend line of the use of prone positions and paralysis in red and blue there. Number of people still enrolled in that shaded blue area. You can see there's an initial higher number, but that wasn't statistically different across time. And in the 3rd week, you can see there's a number of patients that go back to being prone and paralyzed as a tough disease. These are the SOFA scores over time, not much difference. So again, in the first 3 to 7 days, patients are either hypo or normometabolic. Probably 80 to 100% have predicted around that number. They get very hypermetabolic after the first week when they really have changes set in. Some of the other conclusions, I think it's reasonable to look at 20 kcals per kilo, and then feeding probably about 70% of that based on our guidelines for the first few days, and then ramping up to 20 kcals per kilo for the first week. And that's true for both obese and non-obese patients on adjusted body weight for the obese. This seems to be a good target, and they seem to fit nicely around that target. And the weeks that follow, it gets much more difficult, lots of variability. Older people have lower needs, less hypermetabolism, it seems. And then I think fever considerably increases. If you have patients that are febrile all day, they need more calories, we think. They showed a lot more need, as you might imagine. So hypermetabolism doesn't appear to be related to the organ failure severity, and it doesn't seem to be related to paralysis and proning and sedation. We didn't see a lot of differences across time. So I don't know that those are big modifiers here. And that's not surprising. Arthur Van Zandt published a nice paper that showed there was very little difference in paralyzed patients versus non-paralyzed patients who were studied. There's only about a 6% difference in the energy expenditure from paralyzed to non-paralyzed. So again, this is the curve we're drawing now compared to our old curves we used to draw, now that we actually have measured data. And then of course, we can't just give macronutrients, we have to give protein as well, or I'm sorry, we can't just give energy, we have to give protein as well because we need to build muscle. Our protein requirements go up a great deal more in the first day versus our calorie requirements, which usually don't maximize till around day 21, which is what we're seeing in COVID like we do in burn patients, interestingly. And so although we may not need a lot of calories early, we do need protein to prevent muscle wasting and to try to maintain the muscle the patients have and let it recover. And that's because of anabolic resistance. We know that as we age, it takes more grams of protein to gain muscle than it does when we're young. Clearly not all older people lose muscle, although he takes more than nutrition in to look like this. And I think there's a lot we can learn from athletes. Using bolus protein or bolus feeding may be an advantage. We do this a lot at Duke in our trauma patients and some of our others. Bolus feeding probably is more physiologic to stimulate muscle mass. And then exercise and rehabilitation have to be part of that, because the anabolic resistance to critical illness is much more severe. And we may need other interventions like things like oxandrolone, things like propranolol, beta blockers to actually stimulate muscle mass and allow the body to use the nutrients that their hypercatabolic and hypermetabolic state limit them from using. And so we'll talk about that a little bit at the end. So again, we know though, if you can get an additional 30 grams per day of protein in a broad general critical care population you're going to reduce mortality. And this was in about a 3,000 patient cohort that looked at what this amount of protein going in over time did. And our trials show the same. Our large trials like EPINIC and EDEN that gave less than a gram per kilo per day of protein on average, even in the experimental full feeding group, no benefit of additional nutrition versus say trophic feeding. But all the trials that give more than a gram per kilo per day of protein show benefit. Things like the European trial, the TICACOS trial, and the Swiss trial show benefits on mortality or infection rate, reduce infections with better protein, or reduce mortality or better patient time on the ventilator. So again, we need to be getting to guidelines. This is likely the critical nutrient we do need to get in that first week. And again, you can see that in that same study that showed 70% of fed calories led to the best survival. This shows that mortality continues to decrease as you give more and more protein out to above and beyond likely 1.3 grams per kilo per day. So this is critical, it looks like, to reducing death. Then the question is, should we ramp it up like we do energy delivery? We probably should. There's a great observational trial that Arthur Van Zanten did that showed that if you look at the outcomes from the different amounts of protein given on different days, patients who are actually fed a little less protein in days 1 through 3 have the best survival, and then that reverses after day 3. And if you get more protein, 1.2 grams per kilo or more, your survival then increases. So giving 0.8 grams in the first 1 to 3 days is probably best. And so this graph, I think, shows it the best. The patients who were fed poorly in terms of their protein delivery for the whole hospital or ICU stay, they have the highest mortality, not surprising. Patients who get more than 0.8 grams per kilo do better, but patients who get lower amounts of protein in day 1 through 3 and then ramp up after day 3 have the best survival. So I think this is compelling. I think we need some more randomized controlled trials, but I think this is pretty meaningful and makes some physiologic sense if you look at all the trials that exist. So again, I think our protein delivery and our calorie delivery, this is reasonable based on what we've measured and the data that we have right now. And so this, I think, is something you could think about. Of course, we know we don't do a very good job feeding our ICU patients overall. We know that when we survey thousands of patients in hundreds of ICUs around the world, the Canadians do this. We know that we feed about half of what our patients need for not just the first few days, but for the first 2 weeks. We give half of the calories they need. The US has always been the worst, unfortunately. I hope we can improve that, but for 20 years, this is what the data look like. So using enteral nutrition really has not gotten us where we wanted to on its own, and we need to strive to be better and to improve our ability. And protein delivery is even worse. We give about a third of our patients' protein needs for 2 weeks in the ICU, not just for a few days, but for 2 full weeks, which is really devastating. And so if we're going to create survivors, can giving more protein and calories improve that? Does it change quality of life? And I think one key study that you can look to that showed this was a study that Darren Hyland did after we did the redox trial together and published that in New England Journal. We looked at the patients in that study who were on the ventilator more than 8 days. There were about 500 of them, about 475. Patients who got more protein and calories had the best survival versus those who got fed less. And this is in the first 8 days of feeding only. So getting to goal in those first 8 days is really important. And we had quality of life scores at 3 and 6 months, and their quality of life when they were fed, every 25% amount of calories and protein, they were improved upon their adequacy. So the 25% more, they had improvements, significant improvements in their quality of life months later. So how you feed in the first week affects the quality of life months later. And I can't drive that home enough. So you have to be paying attention to how the patient's fed in the first days of ICU stay if you want to optimize the survival of the patient months later in terms of their functional abilities and their quality of life. And this seemed to come back to protein as well. We could see giving an additional 30 grams of protein significantly improved quality of life scores on its own. So we have our patient who's now on trophic EN. Unfortunately, it's getting stopped multiple times. The patient on average is getting about 25% of their protein and calorie needs as it gets later and later in their care. And the challenge is getting to goal in these patients, as I'm sure all of you have found, is very difficult. And the GI tract, unfortunately, in this disease is significantly involved in many of these patients, right? Again, there's all these things happening to our patients, and they're very hard to feed. And there's great publications around this. This virus infects the GI tract and damages the GI tract like it does the lung. And so there's significant amounts of GI symptoms that go with this. That's why more than half the patients are stool positive. We've had patients at Duke that are stool positive and PCR nasal swab negative. So we've had people that have only been positive in their stool, which is a little scary. But again, this is a GI disease as much as it is a lung disease. It really affects many organs in the body. And so again, our Aspen guidelines recommend that we should be moving to TPN sooner and have a lower threshold for switching to that when enteral nutrition isn't getting to goal. So again, in this patient, we weren't succeeding in getting to goal, and we were really challenged. And so this is a patient that our data would say, and our guidelines would say, we should move to TPN earlier. Now, the question your physicians may ask is, doesn't TPN lead to an increased risk of infection in ICU patients? And your physicians likely will believe that it does. But I know you, as the RDs who know the data out there, and I'm happy to send you the papers by email, no, that's not true. We have 4 large trials in journals you've heard of, big ones, New England Journal and others, that shows that TPN does not increase infection risk. There's no more risk of putting TPN through a central line than putting saline through a central line based on these data, and there's much data now for this. So don't let that sway you. That is not true anymore. Show these physicians and teach our colleagues this data. Why is that? Lots of reasons. We don't give too many calories anymore. We treat hyperglycemia. When I was a resident, we did, and we let people's glucose go to 300. Many of the trials that show infection risk of TPN were done when glucose wasn't controlled. We get better protein. We do better central line care. We have checklists. We have better lipids. I hope all of you in your hospitals are using the new advanced lipids. No longer, nobody should be using soy lipid anymore, and anybody who doesn't have an allergy to one of the new lipid components, you should be using one of the new generation lipids in your hospitals. And if you're not, go to your P&T committee now and fix that. The one thing you do have to watch, though, is these patients, because of their inflammatory state, we believe, get severe hypertriglyceridemia, even at low propofol doses, and that's when we're seeing it. So you have to monitor serum triglyceride levels daily when you're on propofol in these patients. Don't miss this. This can cause problems. Briefly, what's in our patients' guts? Could it help or hurt them? As you heard, I mentioned the microbiome. We have a lot of data to say that probiotics may be quite useful in patients who are intubated in preventing secondary pneumonias and ventilator-associated pneumonias, which plagues a lot of our COVID patients, especially the long stayers. This is a randomized controlled trial of lactobacillus GG, the NIH funded, that showed a 50% reduction of ventilator-associated pneumonia in patients who received 1 capsule to the mouth and 1 given to the stomach. Again, this was a government-funded trial and had a significant reduction, not just in ventilator-associated pneumonia, but in C. diff as well. And so I think this is a real opportunity to help our COVID patients avoid those secondary infections that really have led to serious complications and death in some of the patients, at least that I have cared for. My group has done meta-analysis of all the probiotic data in the ICU, and again, we see significant reduction in infections, significant reductions in pneumonias, and the sicker you are, like our COVID patients, the more benefit probiotics seem to have. There's a lot of outpatient data to show this reduces respiratory infections. If you're not taking your probiotic, I advise you to take one. We're doing a study of lactobacillus GG. If you know anyone who's become COVID positive or someone in your home's become COVID positive, we would love to enroll you in a trial. This is the website for it. Please contact us. You can enroll online. We'll send you everything at home for free. So what about back to our patient? You know, he's been in the hospital now for a period of time. He's about 2 weeks in. He gets renal failure, unfortunately, from a secondary pneumonia. He gets oliguria, low urine output, and CRT is started. A few days later, 5-6 days later, he actually develops pancytopenia and gets a low white count. His white count's less than 1. It's threatening his life. His platelet count is low. His crit's falling. And we've ruled out all the drug-related etiologies. What CRT-related nutritional loss may be causing his pancytopenia? The really sharp people in the audience will know the answer is copper. So low copper levels cause severe life-threatening pancytopenia, and CRT causes low copper levels. So we know that CRT, which many of our, unfortunately, COVID patients go on, is like putting a hole in the bucket of all our water-soluble nutrients, vitamins, and trace elements, and even protein and amino acids. They just drain out of the bucket. These are not deficiencies created because the patient's inflamed. Copper actually goes up in inflammation. These are not acute phase-related changes. These are true losses. You can measure them in the effluent. The big CVVH machine is a dumb kitty that just wastes all your patient's nutrition right out the bottom of the barrel or the bucket. And so we have to be watching for these. It's true for protein as well. That's why we advise 2.5 grams per kilo for patients who are on CVVH. They should not have their protein restricted, and on CRT, you have to give more because you're losing about 30% of the protein you give out of the CRT filter right out the bottom of the bucket. So again, you can have serious medical complications from copper and other B vitamin deficiencies on white cells. You can get severe encephalopathy from B6 deficiency. I've had patients that look like they had strokes. They got MRIs and CTs. You give them B6 because they're level 0 and they wake right up. And that's true of all the B vitamins. Again, prolonged neuromuscular dysfunction. We know that copper deficiency over time, some of you may have seen this if you work with gastric bypass patients, if they don't take their vitamins, copper deficiency can cause permanent weakness if it's missed. And so we can't miss it. And then obviously thiamine causes lactic acidosis. We have one of our residents who's got a nutrition background at Duke. She's going to be one of our ICU fellows next year. who looked at this. We looked at all of the measurements we've made in CRT and other nutritionally at-risk patients at Duke to look at how common is this phenomenon. And we found that 90% of patients on CRT develop at least one major deficiency in a trace or water-soluble vitamin after 5 days. You can see the most common were copper at 71%, B6 is very common, carnitine is common about 40%. Zinc is less common because actually I learned in the last week that zinc is actually contained in the CVVH bags as like a contaminant per se, and so zinc actually a patient gets a little bit of zinc from the CRT filter. They still can get deficient, but the CRT bags have a little zinc in them just by chance. But the other nutrients can be quite profound. A majority of patients will develop this. Again, large numbers is common. We saw this in other nutritionally at-risk patients with fistulas and things, but not nearly to the degree we saw it in CRT. The other interesting finding is we found that some of these nutrients associated with hospital mortality. Patients on CRT who develop carnitine deficiency die twice as often, and we need to control some of this data for acute illness, but that is a big difference potentially. So carnitine may play a role in outcome that we don't fully understand. We know it's vital to transporting nutrients into the mitochondria, into the cell. That's probably vital for white cells. Selenium showed us a similar effect, almost a doubling of mortality if someone developed a selenium deficiency on CRT versus those that didn't. And so again, there's signals, and this was true for some of the other nutrients with statistical trends, not as strong as those two. And so any nutrient deficiency we found, whether the patient was on CVH or not, of these trace elements and micronutrients, increased your mortality 2.4-fold if it occurred. So these appear to matter, and we need to continue to study this. So these are key things to be checking, copper and B6 and carnitine especially. Be checking these in your patients when they're on CVH for more than 5 days. Thiamine is sort of unique. There's some nice studies that show, NIH-funded studies from Harvard and other places that show a third of septic shock patients on admission are thiamine deficient if you actually measure them. If you give thiamine back to those patients, they have reduced mortality and better lactate clearance. And again, there's the polymeric data that shows that thiamine and vitamin C may reduce mortality that's being studied now in other trials. But the reality is probably all sepsis patients should get thiamine when they come in on vasopressors because you're never going to measure them. You're not going to spend the money. Plus, it takes 5 days to come back. It costs about 50 cents to give. I advocate giving everybody who comes in on pressors 200 milligrams IV once or twice a day of thiamine. That will correct everybody because you're never going to know who that third is. And in the third it appears that exists, you're going to reduce mortality. So I think there's a chance to benefit people without causing harm. I will tell you the ESPEN guidelines recommend all ICU patients get IV trace elements and micronutrients. So in Europe, this is common practice in everybody. So are patients improving now? They're starting on oral nutrition. Will they eat enough on their own? Not likely. We know that ICU patients average about 700 kcal a day. And I think to understand how much it takes to recover from the starvation and muscle loss and wasting that our patients face in the ICU, looking back to this very famous study that I hope every dietitian has read, it's the most famous nutrition study ever done, was the Minnesota starvation trial. So we know that in World War II, malnutrition killed more people than bullets and bombs. And the US knew that to save Europe and Asia, they would have to send food over to help all the starving people that were part of the war-torn regions of the world. But they didn't know how much to send. No one had ever done these studies. So they found 20 volunteers, people that for religious reasons or other reasons didn't want to fight in the war but wanted to help, to volunteer to be starved under the football stadium at University of Minnesota for months to figure out how much it took to recover them. They lost a lot of weight. They lost about 20 kilos. And what they found was it took a diet of 4,000 calories. And again, these people weren't sick. They were just healthy, normal males. It took 4,000 calories for 6 months to 2 years to recover the muscle and weight that they had lost over a few months. Imagine what a hypercatabolic ICU patient needs. This data in previous total energy expenditure calculations in this very famous critical care medicine paper shows this isn't so different in our ICU patients. The total energy expenditure late in sepsis and trauma is about 3,000 to 4,000 calories, just like the Minnesota Starvation Project. How are we going to get this into our patients? They are never going to feel like eating this much. So oral nutrition supplements are essential. We know that ONS reduces hospital mortality when it was looked at in meta-analysis across many trials. We know that oral nutrition supplements reduce hospital complications dramatically. We know that every dollar you spend on those little containers of ONS saves $52 in hospital costs. This was over 1 million patients studied looking at ONS effects in hospitalized patients. And again, we have a large randomized trial showing a high protein ONS reduces 3-month post-discharge mortality by 50% versus a placebo ONS product. So again, we have a large randomized trial showing this. This is essential to improve outcomes. So as we move towards the end, is the nutrition we give, or is the giving enough nutrition enough to win this war? And the reality is it's going to take more than that. If you don't feed a patient well, they're going to lose muscle mass very rapidly. feeding well, giving enough protein will reduce that and slow that, but it won't stop it. Because we as humans, again, are not evolved metabolically to survive COVID-19 or any other major critical illness. Mother Nature never intended this, and this hypermetabolism can persist for months to years. So can we learn from athletes like this, who I assure you do more than eat right to look like that? You have to do more than just eat just the best foods. Can we learn to help our patients recover their muscle and function? Can we use anabolic agents to improve outcomes? And again, we shouldn't give these early in the first 72 hours before they're resuscitated and stable. But we know that in the burn world, if you're burned in South Africa or in India or in any third world nation or in the US, you're going to get oxandrolone for the entirety of your stay. And we know that in at least this NIH Blue Grant trial, it reduced mortality pretty significantly, in addition to reduce the number of surgeries they needed and reducing their wound healing times and improving their function. So we have a lot of data for that. But the concerns always be, does it increase cardiovascular risk or thrombotic risk? It doesn't. We have large studies now that show that testosterone supplementation actually reduces cardiovascular and stroke risk. This is one of those 43,000 people in the Kaiser system that showed that patients who had known low testosterone levels, which almost all ICU patients do after 3 days, when they got testosterone given back, had less stroke, less cardiac events, less heart attacks. And this was shown broadly in even patients with coronary artery disease by another large study in Utah. So again, this is safe when given to people who have known lows. So you need to check these levels. I check totals only, don't check freeze. They cost more and they don't help you that much. They come back quickly. 94% of patients will be severely deficient by day 3. We give it back. There's a couple ways to do it. You can use the patch, not the best absorbed, or you can use the traditional IM cypionate, 200 milligrams IMQ 2 weeks. Again, you have to feed people well or this isn't going to help them, of course. You can also use oxandrolone, which is what the burn unit uses. This is the best way to do it. It's the most anabolic. You can give this to men or women without any virilization occurring. We've used this in the burn unit for many, many years very safely. And then, of course, we have to have exercise. And so we need the whole triad of things to get our patients back. So again, this just came online about 5 days ago. This is a paper we wrote with a group from across the US looking at the combination of bed rest and inflammation and reduced testosterone secretion and malnutrition that leads to the muscle loss and physical dysfunction. And we're going to need likely to use all 3 of these pathways: exercise, anabolic agents, and of course, the fundamental good nutrition and protein delivery to get patients back their lives. I'm happy to send you guys this paper if you're interested. Again, these are the papers that have looked at this. If you want to read more about this, the first one's more about nutrition across the spectrum. The next 2 are more about exercise, testosterone, and metabolic approaches, muscle mass measurements. I'm happy to send you all these. Are very recent papers. So as I close, why is it that an anesthesiologist cares so much about how you are caring nutritionally for your patients? Why do I care so much about nutrition? It's a strange thing for an intensivist anesthesiologist to care about. And perhaps what can we learn to keep ourselves healthy as well? Well, the reality is, I think all of us should care about this because Derek Angus, who's the editor for Critical Care at JAMA, has shown us that we all average 1.7 admissions to the ICU over our lifetime. And so all of us are going to face this with a family member or ourselves. Unfortunately, in COVID, we may face it sooner than we want to. Someday this may be you or someone you love or a family member. And unfortunately, my passion for nutrition comes from the fact that many years ago and for many years since, it's been me. I've used up a lot of your ICU admissions. I've been in the ICU and in the hospital many times. I was diagnosed as a child. This is me at age 15 on TPN. This is why my passion for working with dietitians comes from. Dietitians saved my life. For the year I was on TPN, it was the dietitian who I looked to and who was sometimes my closest friend and ally in recovery. And so I've had many surgeries through my life. I now live short bowel syndrome. I have an ostomy that I've had since I was a child. And I take Imodium every day or I'd be on TPN myself now. And I've been able to do fairly well. I was probably in the best shape of my life in 2014. This is my son and I visiting my grandfather. Unfortunately, about a month after this picture was taken, I ate some quinoa. Don't ever eat quinoa. If you've had surgery, it leads to things like this, bowel obstructions. This was a severe one that led me to end up in my own emergency room with a massive bowel obstruction, a rising lactate of almost 10, and needing to go urgently to the operating room due to that because I had marked bowel edema. I was taken to the operating room, ended up in my own ICU for fear of bowel ischemia with an open abdomen, was on PN for 23 days. This was just a few years ago. I went from looking like this, probably the best shape of my life, to looking like this in 17 days. I lost 1 kilogram of lean body mass or more a day. I couldn't walk down the block without being short of breath by the end of it. And I'd been running daily 6-7 miles a day before that. So no one is immune to this. I couldn't pick up my own child. He's 11 now, but he was only 5 then. I couldn't pick up my own child because even 5 months later at Christmas, I was too weak to pick him up. So nutrition optimization and recovery from ICU and surgery is part of my everyday life. And what does it look like for me? Again, 4,000 calories a day, 2 grams of protein. I like to show this picture of me with my ostomy. I was surfing a few minutes before this picture was taken, and many of my patients feel like their lives are over when they get an ostomy. And I always tell them there's nothing you can't do now that you could do before. There's nothing you can't do with an ostomy that you could do before you had an ostomy. And I hope it gives them some hope, because I watch a lot of people feel like they don't have hope, and there's no reason for that. Ostomy patients lead great lives. So again, these are all the supplements I take to stay healthy and to recover from surgery and ICU. When I travel somewhere, which hopefully I can do again soon, I have to take a separate suitcase for all my supplements. And so again, how many of our patients will know how to do this? Who's going to teach them? Well, the reality is you out there in the world are going to teach them. And the realization that ICU begins the day, ICU recovery begins the day of hospital admission is essential, or perhaps even prehab, even before. And it continues long after hospital discharge. So in summary, how are we going to optimally feed and improve the lives of these patients and create survivors of them and not victims? Well, to do that, we need to improve upon where we are now. We need to target and personalize our nutrition delivery. We need to use our metabolic cards to target our nutrition and personalize it. There's lots of things we can do to prevent COVID: exercise, vitamin D, probiotics. There's lots of things we can do after they're in the ICU, lots of things we can measure and objectively diagnose now with metabolic carts and ultrasounds. And this is how we target it. Keep your goal towards 70% of their measured resting energy expenditure, ramp your protein up slowly, and then increase your calories up more significantly after the first ICU week. And then there's a lot of things we probably need to do after ICU. We have some specific high intensity training programs that we're using iPhones and iWatches for, that we're going to try to study in COVID patients in their homes as well after they leave the ICU. So the hope is we can take patients that look like this with COVID-19 and with other ICU illnesses, have them mobilizing and exercising soon, and have them hopefully with good nutrition, perhaps an anabolic agent, and perhaps the right exercise, have them look like this when they leave the ICU, or at least like this. And with that, I thank everybody for listening and for attending today, and I very much look forward to your questions, and I think this is what we're left to do now. So please follow me on Instagram and Twitter if you want to hear more. I try to post all the newest data that we see in the nutrition world there, and I very much look forward to your questions.
Thank you, Dr. Wishmeyer. This was an excellent presentation, a very personal one as well, which is always very interesting for the audience. So I'm gonna, a good thing is that many of the questions that have come in to the panel, I think you've already answered. So I'm gonna scroll through a few. One is, what are your recommendations regarding starting vitamin D, additional zinc, and additional vitamin C in COVID-19 patients immediately post-ICU admission?
Sure. So, I think, many of you may know we had a very nice trial in JAMA that Karen Amrine published a number of years ago that showed that in patients who had a vitamin D level less than 12, that they had improved survival if they were given vitamin D at 540,000 units as a single dose of D3. Yes, that dose is correct. So there has been a subsequent trial, the Violet trial, since then that showed a trend towards improvement, but didn't quite meet statistical significance. Now I have to tell you, talking to Frank Harrow, who's really a master statistician from Vanderbilt, when he looked at that data, he actually thinks there is a meaningful signal of vitamin D benefit, and he would like that trial repeated. But nonetheless, I think it's useful within a few days of their admission to check their vitamin D. We know that in a large meta-analysis done in the BMJ, a very rigorous meta-analysis of 11,000 healthy subjects, that patients who had vitamin D deficiencies treated had significant 60–70% reductions in their risk of respiratory infection. Every 4 patients you treated with vitamin D in that study had a prevented respiratory infection. So it had a really tremendous effect, because vitamin D is essential to lung macrophages and to lung immune function. It's also essential to muscle mass. You can't optimize muscle mass without having a normal vitamin D. There's a vitamin D receptor in every cell in your body. And so it's the group at Emory has shown, critical care group at Emory has shown in a trial, that giving 100,000 a day, which is a little more realistic for the dosing forms we have, for 3 to 5 days in the ICU will correct people and can shorten the length of ICU stay. So I would advocate checking within the first few days of admission and then repleting at 100,000 units of D3 liquid down their feeding tube for 1 to 3 days, and then recheck them at about 2 weeks and make sure they're remaining normal. And then you can use 50,000 units like we often do. So I do think that's useful. The vitamin C question is trickier. We know that in the burn unit, we give vitamin C at 1 gram of vitamin C IV an hour to reduce lung leak in patients who've had inhalation injuries. It significantly reduces ARDS and fluid requirements, and most of the studies have been done. I've been doing this since probably 1998. It was published in Japan. And then you have the Merrick study that seems to show improved sepsis outcomes from vitamin C, thiamine, and other things. That's being studied right now in a large trial. I do think it's reasonable in ARDS to give 1.5 grams of vitamin C, like the Merrick trial did, every 6 hours. It likely will reduce lung leak. There's some amazing basic science data that shows that if you have a septic animal, you give it a bolus of vitamin C, they stop leaking fluid across their vascular system. I've seen videos that they're almost amazing to even describe. So, and in the burn world, we've done this for years. So I don't think there's much risk in doing that. I think you can likely do it in most patients relatively safely. And it's being studied and being done routinely in a lot of hospitals around the world. So I think that could be reasonable to do. Although again, I don't think the data is as strong for that yet as say it would be for vitamin D or for some of the other things that we can do for patients. The probiotic data, I would say, is much more compelling than the vitamin C data. I would advise you to use a lactobacillus GG probiotic before I would say vitamin C, given the data that exists right now. But I do think there is some role for it. I haven't seen as much data about zinc, so I don't know that I can comment as much there. If they're deficient, I would replete it, but most of the patients that come in, likely would evolve deficiency over time and not be deficient immediately.
Okay, thank you. There's another question about, with the recommendations that you shared on protein of 1.2 to 2.0, should you use ideal, actual, or adjusted body weight?
So again, I think
in obese, I'm sorry, in obese patients, yeah.
Obviously, I think the 1.2 to 2 grams per kilo was targeted at actual body weight in non-obese subjects. I think, moving to either ideal or adjusted body weight in the obese patient, now you're talking probably 2.0 to 2.5 grams per kilo is the range that a lot of our guidelines you will hear discuss and recommend. Again, we have very little data on how to optimally feed obese patients, but these are the recommendations that do exist based largely on expert opinion, and I think they're very reasonable. There's a study going on that Darren Hyland's doing where 2.5 grams per kilo per day of protein is the experimental arm. So I don't think as long as you stay below 2.5 grams per kilo per day in the obese patient on ideal or adjusted body weight, I don't think you're going to create risk for that patient. And so I think 2 grams per kilo is a reasonable target in most patients. And again, ramp it up slowly over that first few days. I don't think I would jump much above 0.8 grams per kilo for the first 2 to 3 days. And then I think I would ramp it up, and getting somewhere between 1.5 and 2 grams per kilo is a good place to be. And then the obese patient, somewhere between 2 and 2.5 grams per kilo on either adjusted or ideal is a reasonable place to be, depending on whose guideline you like to follow the best.
Perfect. So I want to be respectful of everyone's time, and I really want to thank you again for your excellent presentation. It was very, very interesting. So on behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice. Thank you, Dr. Wischmeyer, again. And I hope you enjoy the rest of your day. Stay healthy and be safe.
Thank you, everyone. And feel free, if there's papers that you would like, to reach out to me at my email address, paul.wischmeyer@duke.edu, or on social media and Twitter or Instagram. And I'm happy to send you manuscripts or papers if you'd like them. Thank you for listening.
Thank you so much.